Hello, everyone, and welcome to Conversations with Mark Becker, a podcast produced by Georgia State University. You will find this episode wherever you listen to podcasts. In this and future weekly podcasts, I sit down with researchers and experts who can give us valuable and important information about the coronavirus pandemic. I hope you will find these conversations stimulating and thought-provoking. And if you do, please subscribe so that you will not miss future episodes. Again, I'm your host, Georgia State President Mark Becker. Today, my guest is Harry Heiman, a medical doctor and clinical associate professor in Georgia State School of Public Health. He's a widely quoted expert on the coronavirus pandemic in Georgia and the policies and tactics needed to mitigate its spread. Welcome, Harry.
Thank you very much.
Harry, it's great to have you on, and I know you've been extraordinarily busy during this pandemic. As an expert, consulted, and certainly heavily researched by the media. I thought we would start off with one of the topics that's been in the news a lot recently, particularly because of the strategy that Sweden has taken to the pandemic, and that's this concept of herd immunity. And so for our listeners, could you explain what herd immunity is and why it's so important as we think about this pandemic and what we're likely to experience over the next however many months?
Well, I think the challenge of a new virus, and this is called a novel coronavirus because it's new, humans haven't seen it before, is that we don't have any inherent protection to it or immunity to it. And you can get immunity one of two ways. You can get it by virtue of having had the infection. And again, one of the questions or challenges with this coronavirus is whether or not having had it and having by blood test the antibodies showing immunity actually provides protection. And then if it provides protection, for how long? And the other way is through a vaccine. And as people have probably heard, there are experts all over the world working very hard to develop a vaccine. Whether they're successful and in what timeline, we're not sure. People have projected 12 to 18 months. But again, it's an unknown. But until we have enough people in a population who are protected, either naturally by having had it or by virtue of vaccine, there's a risk to being out in public.
Absolutely. And so let's just talk about vaccines a little bit more. As you've alluded to, there's a lot of talk as if there's a vaccine and it takes 12 to 18 months, as if this is how you do it. There's a process and you get a vaccine. The reality is, we know that if you get a measles vaccine, it works for life. We know with influenza, you're supposed to get one every year, and sometimes it doesn't even work. And then tragically with some viruses, like the virus that causes HIV/AIDS, we're more than 35 years on and we still don't have a vaccine. So what is it that makes developing a vaccine so difficult for a virus?
So just again, to clarify with people listening, from a medical perspective, there are two main kinds of infections. There's more, but two main kinds. There's bacterial infections that are primarily treated with antibiotics. And then there are viral infections. And unlike with bacterial infections, we have very few treatments for viral infections that are curative, that actually get rid of the virus. So even though we're very successful in treating HIV right now, that the treatments are really to hold the infection at bay and allow people who are under treatment to live normal lives. To your point, some vaccines last a lifetime. Some require regular boosters. Even measles, by the way, requires a booster. And then others, because the virus itself can change or mutate from year to year, require annual immunizations. And that's the case with the flu vaccine. And then with all of those, they're not 100% perfect. They're not 100% protective. So on a good year, a flu vaccine might protect 80 or 90% of the population. And a bad year, it might be less than 50%. So there's a lot of uncertainty both in the development and in their ability to protect populations.
Right. And as you alluded to, even with HIV/AIDS, it's not curative. And we had the recent news yesterday that there appears to be some promise with a drug that was developed for Ebola, remdesivir, but at least the reports I saw suggested it may not lead to better outcomes. It may just lead to shorter times of being sick. And so that's, again, another example that viruses are a lot more challenging than, say, bacteria, I guess.
Absolutely. Yeah.
Okay, so as we live through this period, and certainly here in Georgia, we've heard of the opening up. Different states are doing it differently. We don't yet have a national policy that anybody's following, but there's also other countries. And one of the countries that I'm getting asked about a lot is, well, why did we shut down? Sweden didn't shut down, and so, or why did we shut down? South Korea didn't shut down. So could give people some idea of the different approaches, because there is not a one-size-fits-all approach to how you battle a pandemic, and some have to do with the specifics of your country, let's say.
Well, I think something that's really important for people to recognize is that the reason that we have shut down most of the U.S. economy and have moved to a strategy of social distancing, what we call a mitigation strategy, a strategy of reducing impact, is candidly because we were caught unprepared. Were we prepared? Had the U.S. Been resourcing and working the pandemic plans we've had on the books for years? Had we rapidly ramped up testing, had we been investing in our public health infrastructure, we might not be in a situation we're in today. We might have been able to do active contact tracing and case identification from the beginning, been able to use more of a containment strategy, which is what we've done historically, and not had to move where we are today with really shutting down the economy, having people shelter in place, and relying on social distancing. I think moving from here to what's next really requires our having a plan, the resources and infrastructure in place to move back to where we should have been in the first place, which is really more of a containment strategy. There's been a lot of discussion in the media about testing. Testing is critically important, both to identify new cases and then as a tool for contact tracing, but also to do community level surveillance to understand the level of the virus and the disease in the community, and have some sense of the number of people who are asymptomatic or without symptoms, but still potentially contagious.
So, and that ties back to herd immunity. We need that surveillance to have some
Right.
sense of, are we getting to where we need to get to, where in a sense that the situation is not nearly as concerning. But let's talk about those tests a little bit, because there, as you mentioned, there's two kinds of tests. One is, are you infected? The other is, do you have antibodies to the virus? Meaning, might you have already been infected?
Right.
Based on what you're seeing and hearing right now, where are we in testing, and how good are the tests we have?
Let's see. The short answer to those questions are not where we need to be and not good enough. But the answer.
You and I both laughed.
Yeah, but to answer in complete sentences, we're still ramping up our testing capacity, and I think nationally and in Georgia, we're in a better place than we were, but not nearly where we need to be. And by that I mean, in order to move from where we are now to more of a containment strategy, we need to have testing accessible for all people in every community around the state. So we've been able to build out, I think, 49 drive-in testing centers around Georgia, and that's great. But it means that the barrier to exit is you have to have a car. So if you're in a low-income urban community or a rural community and you don't have a car, well, now you don't have access to testing. On top of that, you have to have the ability to deploy those tests. If you have a new case identified, you have to be able to test any contact of that person, including asymptomatic people. To date, we really haven't been doing a lot of testing on asymptomatic. One of the things you read about in the media is something called false negatives, right? People who have coronavirus symptoms get tested, their test is negative, but they're convinced they have it, and sometimes on repeat testing they do. There are very few tests that we have, particularly a rapid test like that, that is 100% sensitive in its ability to detect all people with the disease. And there can be challenges at every phase of the testing. So from specimen collection, if you don't put the swab far enough into the nose, to the way it's carried to the lab, to the way it's processed in the lab. So that's a concern, but one that's one that's fixable. The other kind of testing that you were asking about is more serological testing or blood testing for immunity. And that's critically important, again, for us to understand the impact of the disease across the population, and to have a sense of how many people have it without knowing, how many people were asymptomatic. The estimates are that about 25% of people with coronavirus are asymptomatic, but they can still spread the disease. It's critically important that we understand that.
I would say, and this is halfway jokingly, is most of us believe we're one of the, we hope we're one of those 25%. We've already had it, and that we've got the antibodies, and we just don't know it. But well, in your explanation, your answer, you talked about access to transportation in rural areas or in urban areas, and certainly we've seen hotspots of this virus in Albany, Georgia. Some of the early clusters were in Rome and Cartersville. Certainly, we've had a lot of cases here in Fulton County recently. And one of the things that's become very clear, and the CDC has reported on this, is not every community is being impacted equally. And it's whether it's job displacement, being laid off, or whether it's getting the disease and dying. We're seeing disparities, quite stark disparities, and many of those are based on socioeconomic status, race, or ethnicity. Could you comment on what we're seeing and what's at the heart of it, in your opinion?
Well, unfortunately, what we're seeing is really a perpetuation of what we have been seeing prior to COVID-19, and that is that there are profound disparities, profound health disparities that are tied to social, economic, and environmental disadvantage. And those disparities affect racial and ethnic minority groups, affect low-income groups, and others. And we're seeing those groups being disproportionately punished by this pandemic. In particular, the African-American community, based on both national data and Georgia state data, is carrying a very disproportionate burden of this. Based on Georgia data, a majority of deaths in Georgia have been among African Americans, even though they're only about 30% of the state population. Even more worrisome in Georgia when you look at deaths among healthcare workers, a disproportionate impact on women and on both African Americans of both genders and African American women. And I think it's how that social and economic disadvantage translates to where people live, the kinds of jobs they do, the kinds of diseases they're more susceptible to. So again, it's not by chance that we have more chronic disease in the African American community in our country. It's because of many of those longstanding policies that have placed them at a disadvantage, whether it is related to economic opportunities, educational opportunities, those kinds of things. So their health status puts them at greater risk for both contracting and having a more serious case of COVID. And then if you look at the communities they live in and reliance more so on public transportation, low-income workers are more likely to be in jobs that have been considered essential, requiring you not to work from home behind a safe computer, but on the job to take public transportation. Even in Georgia, if you look at the kinds of businesses that have been reopened over the past week, and you think about barbershops and fitness centers and restaurants, and who the low-income workers are that are in those positions, there's a disproportionate burden on people who are low income and racial and ethnic minority.
Yeah, and you and I both know viruses aren't racist. I mean, they don't seek out individuals, but they do exploit differences that are there. And it's on a conversation I was in earlier today. The individual I was talking to said that based on what they're reading and seeing, it appears that this virus is most damaging to people who have chronic inflammation. And a lot of, would you think that's accurate? And if it is, are a lot of these conditions which have been cited as the comorbidities that lead to worse outcomes, things like heart disease, diabetes, ties to obesity. Is chronic inflammation a part of that as far as you know?
I think chronic inflammation may be a part of that. We know that stress, including the stress of systemic racism, has profound negative impacts on the body and on physiology. But I think if we look only at kind of medical, biological explanations without both recognizing and shining a light on the social and economic disadvantage, I think we're missing a critical part of the story.
Okay, please go ahead. I'm sorry.
Yeah, no, and I think the narrative that is being told nationally is focused on increased risk related to higher prevalence of chronic disease. And while that's true, it fails to recognize the root causes. And I think it's critical that we recognize the root causes, because the same communities are not only disproportionately impacted by COVID-19 and its health effects, they're also disproportionately impacted by the economic and social impacts of this.
So if I give you a magic wand and you get to develop the plan for quote unquote reopening society, how do you, what are the sorts of things that can be, steps that can be taken to mitigate these risks to disadvantaged populations, both in terms of the practices or policies and priorities of opening up and reopening parts of society, but also the communication strategies for those at risk, and both to help them, and so how can the government help and how can they help themselves, I guess is a simplistic way of asking the question.
Yeah, well, I think there are some easy policy steps we can take to support the social safety net. I think that the governor could and should place a moratorium on evictions and foreclosures. I think the whole, if sheltering in place is how you stay safe, you can't do that if you have housing insecurity and instability. So I think that's one important step forward. I think that food insecurity is also a critical problem. I think historically, states like Georgia have created barriers around work or training or other requirements people had to do to be eligible for food assistance. I think there should also be a moratorium on those. I think that we have significant barriers to access to health care. We didn't expand Medicaid. The majority of the 250,000 people in Georgia who are falling in the coverage gap are people who are low-income workers, but ironically don't make enough to be eligible for subsidies in private markets. And I think as we open up our state, we need to think about who are the workers that we're opening up those businesses, working in those businesses, and if they are already disadvantaged and at higher risk, what are we going to put in place to ensure that they're protected? One of the things that really struck me in the governor's executive order 10 days ago when he announced he was going to be opening up some businesses was basically a line that said that providing personal protective equipment would be provided as available and appropriate. I think we need to ensure, as we're opening things up, that we are putting the health and the safety of our citizens, both as workers and as customers, front and center.
Well, Harry, this is terrific. I think it's very helpful to our listeners, and I know that you're going to be staying on the front line, staying engaged in these issues, and I expect for years to come. So really appreciate you being with me today, and look forward to having the opportunity to touch base with you perhaps again as we get further on, because I don't think, given that we're nowhere near herd immunity, there's no reason to believe we're out of the woods with this anytime soon. So
thank you so much. I appreciate the opportunity.
Thank you. Well, this has been Conversations with Mark Becker, a podcast produced by Georgia State University. And you've been listening to a conversation with Professor Harry Heiman, medical doctor and clinical associate professor in the School of Public Health. To hear future conversations with experts on the front lines addressing the coronavirus pandemic, you'll find Conversations with Mark Becker wherever you listen to podcasts. Thank you for listening, and remember to subscribe so that you will not miss future episodes. Goodbye for now.